Everyone. I'm so grateful to have this opportunity to be presenting my work to you, which I did for my research study. This study was triggered by my exposure to fetal medicine unit, where we discovered a high percentage of pregnant women had fetal growth restriction. Therefore, I decided to perform a study entitled Ultrasound Evaluation of the Placenta in Pregnancies with Fetal Growth Restriction. As you all know, placenta is a critical organ to development and well-being of the fetus, as some of its main function is to supply oxygen, nutrients, and food to the fetus. A background of my study: the fetus health is dependent on the mother's ability to supply enough quality and quantity of growth substrates through uterine arteries, as well as placenta's ability to transfer these nutritional substrates to the fetus. If one of these processes is altered, it can lead to fetal growth restriction, which is the inability of the fetus to grow according to its maximum predetermined growth potential. And globally, it is known to be a significant contributor of perinatal mobility and morbidity. The etiology of fetal growth restriction is mostly anchored on placental insufficiency, which can be due to perfusion or regression problems. Placental senescence can be a clue for fetal growth restriction, as mentioned in a study done in 2011 by Krishna and Palero. Therefore, placental grading and uterine artery assessment may play a vital role in evaluation of FGR secondary to placental insufficiency. The main aim of this study was the assessment of the placental appearance and perfusion in FGR cases, and specific objectives of this study was the determination of the proportion of FGR pregnancies with abnormal placenta grades, determination of proportion of FGR pregnancies with abnormal uterine artery droplets, as well as the association between placental grading and uterine artery blood flow in FGR cases. This study was a retrospective descriptive study that included 522 single-term pregnancies that have been diagnosed with fetal growth restriction during the period of 20 to 36 weeks at Parirenyatwa and Salim Babe Fetal Medicine units. Ethical approval was granted from Joint Research Ethics Committee, and the parameters that were mainly focused in this study were the uterine arteries as well as the placental grades. So the placenta was graded according to random classification, and uterine arteries were categorized into normal and abnormal based on the Gomez reference chart, such that all uterine PI values that were greater than 95% were categorized as abnormal uterine artery PI values. Here are the interesting findings of the study. The study showed that a higher proportion of placentas were abnormal, and this is being depicted by a 72% of grade 3 placentas. Moving on, the study showed that abnormal uterine artery Dopplers were dominating in our cases, and it is being depicted by mean uterine artery Dopplers that were about 57% of abnormal mean uterine artery Dopplers. And when I used either right or left uterine artery Dopplers, about 66% were abnormal uterine artery PI values. Further on, the study showed that about 50% of the cases had the abnormality of both the placenta and the uterine artery Dopplers, and about 38% had the abnormality of either placenta grade or uterine artery Dopplers. 9% showed both the normal placenta grade and uterine artery Dopplers. Furthermore, logistic regression was used to find the association of these variables with fetal growth restriction, and the findings showed that abnormal placenta grade and abnormal mean uterine artery Dopplers, as well as the right or left uterine artery Dopplers, have positive association with fetal growth restriction, as being shown by odds ratios that are far much greater than 1 and lie within our confidence intervals. Data was further categorized into early onset and late onset, and the findings were relatively similar, such that we can generalize our overall findings both early and late onset. Furthermore, chi-square Pearson was used to find the association between placental grading and uterine artery dysplasia, and findings showed that in early onset and late onset, there was positive association, but the association was statistically insignificant since the p-values are greater than 0.05. But in overall cases, either right or left uterine artery dysplasia proved to be good association with placental grading as being depicted by p-value that is less than 0.05. This means our study proved that abnormal placenta grade and abnormal uterine artery blood flow were significant indicators of placental insufficiency. These findings were in line with the findings of a study performed in 2011, and either right or left uterine artery proved to be a better indicator of placental insufficiency as compared to the mean. Findings of this study can be generalized in both early and late onset since the results were relatively similar. Clinically, the findings of our study showed that about 53% of cases had the abnormality of both the placenta grade and the uterine artery, whilst 47% of the cases had abnormality of either placenta grade or uterine artery PI values. This categorization implies that finding an abnormal placenta grade and an abnormal uterine artery PI during ultrasound scanning may suggest the presence of patient-related placental insufficiency. Therefore, this will help in the clinical intervention. For example, in late pregnancy, the fetal growth restriction is being caused by patient-related placental insufficiency. A pregnant mother can be given calcium carbonate since it will help lower blood pressure and to dilate the vessels. If it's non-patient related, pregnant woman can be given Clexane, which can help to reduce or prevent clot formation in the placenta. In conclusion, better understanding and identification of placental insufficiency may improve monitoring of FGR pregnancies with the aim of delivering viable pregnancies and reduce chances of stillbirth that was estimated to be about 65% in a study performed in 2016 by yourself. Therefore, the documentation of placenta grade and uterine artery Doppler in the third trimester scan should be routinely practiced. Use of either right or left uterine artery is recommended. Abnormal placenta grade and uterine artery Dopplers must be used as FGR indicators. In summary, we are not saying uterine artery Doppler and placenta grade should replace other parameters that are already used in settings like fetal Dopplers, but we are saying they can complement each other in so as to improve our monitoring and management of FGR cases. I would like to acknowledge Mrs. Zanga, who was my supervisor during my research study, and Dr. Verenga, who was a co-supervisor to my study as well. Special thanks to fetal medicine unit staff at Parenia Salim Gabe fetal medicine units for their support and provision of primary data that I used for my study. Thank you all for listening.